Good morning and welcome. I will call to order the Board of Health meeting of October 25th, 2023. We're going to start the meeting with executive session for up to 15 minutes to discuss the legal counsel matters relating to agency enforcement actions and potential litigation. Good morning and welcome back. And we have Commissioner McKinney and Commissioner Lindy online this morning. So we're going to start with Mr. Ibach, if you would do introductions.
Okay, we do have one guest in the back and we also have a new staff member. So I'm gonna go ahead and introduce him.
Yeah, good morning, everybody. This is Robert Weaver. This is our new environmental health specialist. He joined us on October 9th. So Robert, do you want to tell us a little quick?
Yeah, I'm from Yakima. I grew up here. Some quick fun facts. I have a cat named Franklin and I have a background in biology. In the past, I actually used to assist on autopsies in New Mexico. So, but I'm from Yakima and I love the job so far. It's been really exciting. So looking forward to working here.
Well, welcome and
Thank you.
So I have a cat named Doofus and we'll talk about that later.
Franklin is my first male cat. He can be kind of a doofus. I used to always.
Not where I thought the meeting would go.
And we do have a guest in the back also.
So my name is David Trimble. I'm a nursing student from Heritage University. I'm also from Yakima. Don't have a cat. But I have two little boys, a wife, and then a little dachshund who thinks he's a pit bull. So that's fine.
Welcome.
You'll notice we've had quite a few nursing students from Heritage University. We partner with Heritage University and WSU for their nursing students. So they do a clinical placement here for the health.
That's great. Great partnership. Thank you. Are there any other directions?
That's it.
Do we have any public comment?
There are no public comments submitted. I don't know if you have a public comment you want to make or.
Not at this point.
Okay.
All right, thank you. We'll move on to the consent agenda. And all the items listed below with the bullet point are considered routine by the health board and will be enacted by one motion. There will be no separate discussion of these items unless the board of health member requests, in which event the item will be removed from the consent agenda and considered in this normal sequence on the agenda. Does any member of the board wish to remove an item from the consent agenda? Hearing none, Mr. Ibach, would you read that, please?
Yes, September 27, 2023, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll in September 2023 in the amount of $790,039.72.
Thank you. Do we have a motion to approve?
Motion. I'll second.
Next, we have a motion and a second to approve the consent agenda as read. All those in favor, please say aye.
Aye.
Opposed.
Aye.
Motion passes. Thank you. And we're going to move, we're changing the agenda a little bit. We're going to move into unfinished business, starting with the 2024 budget hearing. And Mr. Ibach, do you have anything you want to say before I open the hearing?
Okay, yes, we did advertise the public hearing for the budget in the newspaper and also on our website. We've had the budget on our website, it's also been on in our lobby for anyone for the public to see it.
Thank you. So have we, I'm going to open the public hearing at this point. Do we have any comments in writing today?
There are no comments that were submitted. I don't know if any of our guests have. Okay.
No comments. All right, then I will close the public meeting portion and we'll start with discussion.
Okay, so last month's meeting, we issued the budget to all the board members to review. And there was just one thing that we want to clarify, that's something that was brought up in last meeting, and we also worked with Commissioner McKinney on prevention specifically for opioids and fentanyl. And so we have designated line budget line number 806 to be just for prevention only, right, for initiatives, campaigns, and for staff time, just for prevention on opioid and fentanyl.
Thank you very much. So I want to make sure you heard from Commissioner Lindy and Commissioner McKinney while you're here. Do you have any comments?
If I may go, Commissioner McKinney, I just want to thank Chase and Ryan and Andre. We did discuss this through email, and I think it's an incredible win for our community to be able to identify this as a specific line item. I think we've all, discussed this at length, but prevention, especially in youth, is critical to really push back and fight against this scourge. And I'm really eager to see the data that comes from being able to track it. And I hope that we're able to reach a lot of folks with this prevention for opioids and fentanyl. I just want to say thank you.
I want to thank the board too for their interest in this area. Obviously, it was made very clear by the board in recent meetings that it's not just trying to address the issue of overdose now. It's the idea of preventing people from becoming interested in using these drugs to begin with. So we are encouraged by that, and also our staff has been working with our partners. So you'll hear more of that from Lillian's department in the coming months.
Thank you, Mr. Fusco. Commissioner Lindy?
Thank you, Councilmember Byers. I would just echo the sentiments that to me, education prevention is key. I mean, it's wonderful when we can treat people and help them overcome these terrible addictions, but we're so much farther ahead if we can prevent it in the first place. Thanks.
Other questions or comments? Any discussion by the board? Well, I just want to personally thank the board for all the work in going through the budget and making a very important suggested amendment. Thank you for the staff for responding very quickly and being in agreement with that, and for all the work done there. So at this point, if there's no further discussion, I would entertain a motion to approve the budget.
I move that we approve and adopt the 2024 budget.
I second.
Thank you. So we have a motion and a second to approve and adopt the 2024 budget. And because it is budget, I'm going to ask for a roll call vote, please.
Right. So if you're in favor of the motion, please state yes. If not, please state no. So Commissioner Lindy,
Yes.
Edie Dibble.
Yes.
Commissioner McKinney. Commissioner McKinney.
Aye, sorry for the delay. Yes.
Stephanie Algren.
Yes.
Bailey Ackerman.
Yes.
Peter Carrillo.
Yes.
Dr. Atterbury.
Yes.
Commissioner Curtis.
Yes.
And Patricia Butters.
Yes. So we have a unanimous vote. Thank you very much to the board. Appreciate that. It passes. Yes, you may.
I just want to thank the board certainly for their support in passing this budget, but also doing so in October, which allows us a great deal of time to plan for next year, which makes life far easier for us considering we don't have a meeting in November. Also, again, this is a strong budget, a balanced budget. It allows us to maintain services and certainly increase those services to the community. And I did want to reflect on the fact that again, in previous years, we've had many concerns about budgets and funding streams being cut. That has not been the case this year. So we are very encouraged and again, grateful to the board for adopting it.
Thank you. All right. Then we're going to move ahead to the spotlight, which is the drinking water program.
Good morning, everybody. So today we're going to go through the Yakima Health District's drinking water program. Talk about kind of the different services we provide and what we do around drinking water in Yakima County. Next slide, please. So going through, we have 4 different types of wells or water systems that we'll be talking about today, ranging from an individual single connection well all the way up to our Group A water systems, which could serve, you know, as a small municipal system, city of Matthew, for example. Next slide, please. Okay, so we're gonna kind of go in ascending order here from individual wells all the way to Group A's. A lot of the information transitions from one type of water system to the other. So I'll just kind of highlight the changes to each water system as we go. So for individual well, the criteria for that is it's a single connection well that serves a private single family residence. Requirements, and this is some of the stuff that's repetitive through this. Requirements for a connection to a drinking water well is at least a 5 gallon per minute flow. We need to have our nitrate levels below the maximum contaminant level for nitrate, which is 10 part per million, and also the absence of coliform. So these wells get sampled before they are approved as a drinking water source. Next slide, please. So our regulatory involvement, individual wells are some of the least regulated water systems out there. However, the health district will works in partnership with Yakima County Water Resource Systems. We conduct what's called an adequate water determination, or an AWD. We're looking at quantity and quality of a well or each connection to that well. So looking for the 5 gallon per minute per connection, the absence of coliform, and nitrate below the 10 part per million. So every new use well that exists goes through our AWD process. We also work in partnership with Department of Ecology on doing well seal inspections. Basically, it's an inspection of a newly constructed well or an inspection of the well during the construction process while it's being drilled. We're looking for the ecology well seal, which is kind of a clay seal around the wellhead, protects from surface water running down the wellhead into the aquifer, that is properly capped, screened, has its well ID tag number for Department of Ecology installed on it. Also, there's the Yakima County Water Resource Systems for the metering for each connection on a well. Also the water rate services that folks have to secure through Yakima County. Next slide, please. So moving into our next water system up, it's a shared well or a group C well. There's slight differences here. Criteria for a shared well, it's a 2-connection well. Serves 2 single-family residences or a duplex or a single-family residence, an accessory dwelling unit, also known as a mother-in-law. That's what triggers the criteria for a shared well. For a group C well, this is a well that would serve like a small outbuilding at a place of work that is only used by a few employees intermittently. It's a single connection, so it's not a public water system, but it is a higher level system to serve people at a place of work where there's less than 5 people served per day. So it's a new kind of criteria we created to allow a little more flexibility for places of work to get an approved drinking water source without going through the pretty robust Group B process. They also could qualify for some small in-home early childhood learning centers or daycares. Next slide, please. So again, the flow, the nitrate, the coliform, it's all the same as individual. The differences here is that we actually conduct a site inspection of the wellhead or the proposed location of a new well. There's criteria that's set forth by the WACS. There has to be 100-foot sanitary control area around the wellhead where there's no possibility for contamination, no surface water, no buildings, no septic systems, those kinds of things. We'll also have to have legal protection documented on the title of the property, which is protective covenants, which secures that sanitary control area. Nobody can construct anything or alter that area. Water users agreement, so all parties involved have legal access to the water in that well, and access easements that all parties involved or a water system manager has legal access to that well for maintenance.
On a shared well, are there limitations on the number of people using or the number of households using the same well?
It's 2 connections, so it can serve. Well, I mean, if you're serving 2 residences, you're highly unlikely to serve more than 25 people, but it would have to be less.
Thank you.
Sean, I thought your last slide said it has to be under 5 people. Maybe
Less than 5 people for a Group C. Well,
It's either one facility with less than 5 people or 2 households, for example.
Yeah.
okay.
Next slide, please. So differences here for the regulatory involvement is we conduct a site inspection and we review the design work for the system. So we have full authority over the approval or denial of a shared/group C well. All the other regulatory conditions are the same as individual. Next slide. So moving into our Group B water systems, these systems serve less than 25 people, less than 60 days, or they serve 25 or more people fewer than 60 days a year. It gets a little convoluted, or less than 25 people on an ongoing basis. Or on the residential side, it's 3 to 9 residential connections, period. 3 to 9, it's a Group B. If we're talking about commercial connections, then we look at how many people it's serving, how many days out of the year. But these could be used for churches, small businesses, agricultural facilities that are kind of on a smaller scale. Next slide, please.
Question, John. So in a type B, is it still just the 5 gallons per minute
Per connection.
per connection? Per connection, not per the whole well.
Right.
Thank you.
Next slide, please. So looking into the requirements here, we have full authority over Group B designs and reviews, so we do the site inspection for approval. We have a Group B design workbook that must be completed, typically by a licensed engineer. In most cases, that's what we receive. It's not required, but that's the route a lot of people choose to take. And we do the full review of that Group B design, and then we do a post-construction inspection before the system is put into operation. And then for the water sample, the difference between from a shared and an individual is that they must conduct a full inorganic chemical panel. So it's a much longer list of analytes they have to get a laboratory result on to get a Group B approved as a drinking water source. And then again, legal protections, covenants, all that, water rights, it's all the same. Next slide, please. So actually, the regulatory requirements are pretty much identical to a shared well. So we really don't need to go into that, but yeah, same regulatory involvement as a shared well. It's just a much more robust review process because we're looking at, sometimes 100-page workbook. Next slide, please. Okay, so moving into our Group A water systems, I'll preface this with that these are fully regulated by the State Department of Health. The Yakima Health District does not regulate Group A systems, but we do work in partnership on them. So the criteria for Group A is 10 or more residential connections, or any number of commercial connections that serve 25 or more people for 60 or more days a year, or 1,000 or more people for 2 consecutive days. Good example of that is the location of Chinook Fest. Big festival, 3 days long, a couple thousand people a day. Requires a Group A water system. So there are different types of Group A systems. Community Group A water system is for a residential population, so it serves a housing development. Non-transient, non-community serves the same population, but it's not residential. So a place of work, fruit packing warehouse, large scale commercial businesses, large daycares, those kinds of things. Transient, non-community, changing population, non-residential, gas stations, rest areas, parks, campgrounds, for example. Next slide, please. So the differences here is that there's still the site approval, the well site inspection needs to happen. It's approved by the State Department of Health. However, we will go out and conduct the inspection, collect data, take pictures of the site, and we will send that to the state for them to make a determination if that's an adequate well site. The design workbook reviewed and approved by the State Department of Health. All the water sampling requirements is regulated by State Department of Health. In addition to the full inorganic panel, other samples could be required by DOH. For example, ESELA or for PFAS, it's a known area with a contaminant of concern. DOH could request that there is a PFAS sample added to the list of analytes. The other difference is routine inspections. We call them sanitary surveys. We partner with the State Department of Health, and our staff goes out and does these routine inspections on our Group A water systems in Yakima County every year. It ranges from, one year we could have a dozen, the next year we could be inspecting 40 of them. So they're very in-depth inspections. We're looking at every component of the water system and the environment around it for possible points of contamination. And these happen, each system gets an inspection every 3 to 5 years based on their performance through the routine inspection. Next slide, please. So regulatory involvement, we don't have as much regulatory involvement in Group A's outside of the sanitary surveys we conduct. We don't really even make the requirements during that inspection. We write up the survey, we make our notes, we make observations, and we make recommendations based on what we see to the State Department of Health. They approve our inspection report and then send back a corrections letter to the water systems purveyor to make those corrections. So it's a very kind of fluid partnership, pretty seamless effort, and we've been conducting sanitary surveys for years. All the other regulatory involvement requirements are identical as the other 3 water systems we've already covered. Next slide, please. So I want to dive back into our Group B programs. As you may have heard, we're working on a draft Group B ordinance for Yakima County. And there's 3 different kinds of Group B programs that exist in Washington State. Some counties don't have a local Group B program. They don't exist at the local level. So the State Department of Health maintains authority, and as I understand it, the State Department of Health doesn't really have a Group B program. So the counties that don't have program don't have Group B wells. So what Yakima County currently has is what's called a joint plan of responsibility. So that means we are required to follow the Group B WAC for approving Group B water systems. Now, there's limitations to that, as there's no provisions for treating primary contaminants in the Group B WAC. So the health district cannot approve Group B systems that have a primary contaminant present when they take their initial sample. We can't approve treatment. It means the system dies right there. The next is a full authority under a local ordinance. This is what we're working towards. This means that a local health jurisdiction such as YHD can add its own provisions to the local ordinance, which gives us the authority to approve treatment of primary contaminants. We would be the ones to review that, evaluate that, and monitor the ongoing sampling of those systems to make sure there's long-term success of a treatment system that's in place. So you can see that there's many counties around the state that do have a full local ordinance at the local level. It's something we're working towards and having a draft finalized.
Sean, what's the history behind that? It would seem to me that we should have always been full authority under a local ordinance. Is there some history of why we didn't go that route, or?
I can add.
It was before my time, so.
Yeah, basically what happened was the state decided because of lack of resources to get out of the Group B system. And that was a concern for us. How long was that about?
16, I think.
Right. So we worked with the board and certainly commissioners on the idea that we wanted to be in full compliance. We also wanted to protect future homeowners so that someone puts in an appropriate well system. It's a shared well system. We didn't want somebody moving into a home and not have an adequate water source. At the time, the answer with the delegated authority made sense. We weren't concerned about primary contaminants because this wasn't really a main issue. What's coming up now is the main concern is PFAS. Now we're talking about contaminants. We're talking about water rights. We're certainly talking about the value of homes. And we also, in a community that requires more homes in the future, we want to make sure that people have options in terms of future construction. So that's why we're committing to the idea of a local ordinance. And again, by state law, you can be more stringent, you can't be less. So again, we can adopt something that has more requirements rather than less requirements. Again, I think this is an issue from an environmental health standpoint that is very critical for our community. We have issues with nitrates, PFAS, and we may have other contaminants in the future.
Thank you.
Next slide, please.
Don have a question.
Oh,
Yes, I'm sorry. I up in the corner, I could barely see it. Thank you. Go ahead, Commissioner.
Well, yeah, I actually had a question and Andre actually answered the question because I was wondering what the implications might be if we can't treat for primary contaminants, but we have the issue such as PFAS that is, surfacing right now. So anyway, question answered.
Oh, and if I may, thank you, Commissioner. We have a number of people now who are very concerned about their water systems, but the idea that someone may not be able to subdivide land or may even be concerned about having contamination in the first place, we certainly, and I don't know if you want to address it, Sean, but we don't want people to drill a well only to find out there's a problem and then not be able to accomplish their task. I mean, that is a financial concern for people. It's a tremendous investment, and we certainly don't want people to be apprehensive about building in our county.
Yeah, and that is a huge concern for us. Is there's no way to know there's a primary contaminant until we have a water sample, and that means you have to drill the well first. Drilling a well can range from $30,000 to well over $100,000, depending on how deep you have to go, and to make that investment just to find out I have PFAS. I can't have this system approved as a group B. It's supposed to serve 9 lots in this development. And it's dead in the water. So a local ordinance would mean they could come to the health district. And during that review, they say, well, I got PFAS. Okay, well, we can, there's these numbers of treatment systems that would qualify to reduce PFAS levels below the maximum contaminant level that you can get your system approved. By the way, here's the sampling schedule thereafter to make sure your treatment system is still working. So is it an added cost to add treatment? It is, but then again, that versus shutting down a whole development project, I think is could be worth it. And we're also opening up vacant land currently or potentially in other areas that may require treatment without, putting property values at risk. We're able to preserve that through allowing treatment of primary contaminants. We got a little bit more to go. Next slide, please. Okay, so the regulating of contaminants for group Bs. There's primary contaminants, secondary contaminants. Secondary contaminants don't pose a threat to public health. We're talking about contaminants that affect taste, odor, clarity of the water, just more aesthetic things, contaminants that make water too hard or too soft, and those treatment for those is allowed. Soda ash, rock salt, on a water system is a pretty common thing to see, and those are what those components of a water system are treating for. So secondary contaminants to kind of balance that drinking water source and make it more aesthetically pleasing. And nobody wants an orange t-shirt that used to be white coming out of the washing machine. Moving into primary contaminants, those are contaminants that pose a direct threat to public health. Major ones, E. coli, lead, benzene, cyanide, arsenic, nitrates. We've heard about all of those. Currently, the Group B WAC has no provisions to allow any system to have treatment for that. So again, us having a local ordinance that goes beyond the WAC gives us the ability to do that. So next slide, please. So our proposed Group B ordinance, the PFAS situation in ESILA really kind of kicked us into high gear of realizing, we need to go beyond what we're doing now with our Group B water systems. We need to enhance our services and be more of provide more of a resource to give people options in the development of property, people who have existing Group Bs that need to add treatment. For example, there's a couple Group B systems in the ESILA area that are receiving treatment systems paid for by the Department of the Army. We need a local Group B ordinance for those treatment systems to be valid. So we see that's what's kind of driving this, but recognizing now more than ever, we realize there's more contaminants popping up. We don't know what's going to be next or what area of Yakima County is going to be next, but this ordinance would allow us this ability across the entire county, not just in the current area where PFAS is a concern. I lost where I was.
Do you mind addressing the issue that one of the pressing issues is the EPA changing their?
Yes. So another driving factor in this is currently the federal standard is 70 parts per trillion PFAS as the maximum contaminant level. It is expected that at the earliest, January 2024, I don't believe it's going to happen, but the EPA is going to change the maximum contaminant level to 4 parts per trillion, which is the lowest level that any laboratory can test for. That's why they're setting it there. And in following suit with that, the State Board of Health is going to adopt PFAS as a primary contaminant because it's a known carcinogen. It poses a threat to human health. So once those chain of events take place, current Group Bs that have PFAS would not be allowed to have a treatment system installed unless we adopt a Group B ordinance. So we're preventing current water systems from having to shut down. We're also opening possibilities of land that has yet to be developed in areas where there's contaminants of concern. We're also have an avenue to protect future areas if other contaminants pop up.
Does the Department of Health not subscribe treatment?
They don't have a Group B program, period. There's just the law that regulates it.
It won't make a lot of sense, because they can add it, they're the entity that adds the contaminants. We don't add the list of contaminant to the list, right?
Right.
So they add a contaminant and all of a sudden you shut down all of our systems, but there's no treatment that they can prescribe. That don't make sense.
It also didn't make sense when they moved away from the oversight. It was an immediate change, and again, counties had the privilege to either adopt something locally or not. We created a fee schedule, and we thought it was really important, but it was optional, which again does not protect public health.
Yeah. And when we get to finally being fully localized and having that local authority, we don't get to have control over what gets added to the list of contaminants.
No, that would still come through the State Board of Health. Next slide, please. Okay, I will say though that going to a local Group B ordinance, adopting that, we do get more funding from the state to run that program and pay for some of the ongoing monitoring and water sampling and more extensive reviews. So it does cover a lot of our staff time. I believe the funding doubles. I don't know exactly what the number is off the top of my head right now, but I can certainly get that. But looking at how this ties into our strategic goals, you know, our drinking water program is one of our mandated services. So if you look at the drinking water program in itself and then take the Group B ordinance as a kind of a separate component, we're enhancing our mandated services. We're being more of a resource to the community and bringing more options to the table to keep building progress and public health moving forward, a healthier community moving forward. This program definitely has secured many partnerships with the Yakima County Public Services, the Water Resource Program, partnering with them and looking at quality of water for the water rights, working with ecology on well construction, and with the Department of Health on our sanitary surveys and developing these programs. So the increasing of effectiveness and efficiency, this I'm looking at more as an effective. The effective side of this, having a local Group B ordinance would make us more effective in securing clean drinking water for more people in the county. Also, and from an efficiency standpoint, it wouldn't hold up land development. It would allow us to keep land development progressing, especially in areas where we have known contaminants. Next slide. Any other questions?
Yeah, so just on the idea of the list of contaminants, I mean, in the spirit of being able to make stricter ordinances, is there something that would stop us from being able to identify a contaminant in the area and say, hey, we need to add this or we need to address this?
Well, the financial constraints would probably be the number one thing. Because when you add further regulation, you're creating a lot of expense to enact that regulation and then to retro the people that are out of compliance. So I think that's probably the major thing.
So, okay, if you didn't make it regulatory necessarily, but just, you know, identifying and doing like a public awareness, you know, or saying here's an identified potential problem or.
Yeah, we did that with the PFAS situation when it first came out. PFAS is so new. And we're learning a lot about it very quickly, but it's still so new that there really isn't much of a regulation for it because it doesn't exist on the primary list of primary contaminants yet. There's a large gap between the state maximum contaminant level and the federal maximum contaminant level. And it's hard to, you know, we can certainly educate people on the risks of PFAS, but we don't have the authority to say you have to do this. Especially with Group B systems. Individual wells, we don't regulate them. We can't force anybody to do anything with their individual well, but we can make recommendations. Shared wells, we have full regulatory authority over, no PFAS, we can say, well, you need to get a treatment system for that. Here are your options. There's lots of options out there. Yeah, there's some areas or some water systems we have authority over. There's others that we absolutely do not and can't make anyone do anything. So that's why we take that educational approach, try to provide resources, get Department of Ecology and Department of Health involved. In this instance, the contamination is coming from the Yakima Training Center, so the Army is stepping in and also trying to provide resources and plans moving forward on how to address this issue. So I know a lot of the wells that tested with PFAS, they're starting with all the wells above the current federal limit of 70 part per trillion. They're putting whole house treatment system on their wells. So most folks there, I believe, and once the EPA changes their maximum contaminant limit down to 4, Army is going to go back retroactive and install basically a treatment system on every single house that tested for positive for PFAS. So people are getting the resources, but we don't have the authority to say that.
Yes, Commissioner Lindy, had a question, I believe.
Yes, go ahead, Commissioner.
Thank you, Andre. Oops, can you hear me?
Yes,
Yeah.
you can.
Okay, very good. So I was wondering if you could clarify one thing. So when we're talking about the ability, this pursuit of local authority, I'm assuming that what this means then is that if somebody wants to, put in a new system, then we would have the full authority, because at the moment, if they're drilling and they find a contaminant, then they can't move forward. But what happens with the Group B systems and the like that are already in place? I'm guessing you can't just shut them down, but you're offering recommendations for treatment. Am I understanding that correctly?
Currently, under a joint planner responsibility with no authority to add a treatment system to an existing Group B, they would be required by the state, the way the WACs and RCWs are written, they would not qualify as a approvable drinking water source anymore and would have to discontinue the use of the system. Now, with the local ordinance, for example, there's a couple Group Bs in the East Gila area that have high levels of PFAS. The Army is installing a treatment system for those Group B water systems. So if we adopt a local ordinance, we could follow up with saying the treatment system is working based on the sample results. They maintain their approval as a Group B system. We would have the authority to say that.
Okay, so in their current systems, then there is still the potential that a system could be shut down unless they get the help they need or the mitigation in place to treat the primary contaminants.
Correct.
Well, just to clarify, currently, if you're a Group B system and you have a contaminant, you are not able to move forward with any treatment.
Correct. You can't chlorinate.
So that is why it's vitally important that we get this local ordinance thing taken care of so that we can actually ensure that in the event there is this new contaminant that is added, folks aren't being without water.
Yeah. And in a nutshell, the ordinance is basically geared to mirror what we do now.
Yep.
We take in a design workbook, we do the site inspection, the same approval process. There's the section that talks about what evaluation goes into play for a treatment system. We need the specifications, the longevity of the system, the maintenance plan for the treatment system, and then a monitoring schedule. So if it's quarterly, if it's annually, that can be a kind of a case by case thing depending on the contaminant we're working with or the treatment system in place. And then there's language on, if a system is out of compliance, what corrective actions there are, or if it's willful neglect or willful non-compliant, what that looks like.
And if I may clarify, I'm sorry, Ms. Hartman.
What does it take to change to become the local authority? What's the process and what do you have to do?
We draft a Group B ordinance, the board reviews it, and the board votes on it.
Oh.
Seems pretty simple.
It's coming.
Well, and I was gonna share that again, to Ms. Ackerman's point about different contaminants. These are emerging issues. The state, the federal government have not addressed these. The contaminants that came from PFAS was part of a fire retardant system, which was actually considered quite safe and considered beneficial because it could put out flames in massive quantities. So we're dealing with an emerging issue. Sean has elevated this issue. He is now part of the leadership group for the environmental health directors around the state. So that's wonderful. And I had a meeting with the Secretary of Health the week before last, and we talked about issues that we needed to address here. And we mentioned that environmental health and safety is pivotal for us in Eastern Washington. And these are issues that are serious concerns, especially in the agricultural community. It's been made very clear that investments have to be made to support local communities like ours. So it's very much on the table. No one's ignoring it, but the speed of government does not always catch up with the needs of the community. So that's why we're trying to be proactive.
So I was going to say, and I appreciate your sharing that, Mr. Fresco, because I was going to say in response to Commissioner Kyle Curtis that sometimes what happens in the stateside in Olympia does not make sense. But I'm glad they're willing to give us money to do the part that they're not doing. And I want to commend the health district on moving forward. This is a really critical area to protect not only the safety of the water for the entire county, but also rights and protections for homeowners and property owners as well. So critical issue, good time to move forward. Thank you.
And on a lighter note, it's not gonna be that many pages. It'll be pretty light reading for you. Yeah, a couple pages.
Any other questions or discussion? All right, then we will move on. Thank you. We appreciate that, Sean. We're moving into agency reports, starting with the executive director on the history.
Yes, good morning to the board. Thank you to our guests. I just wanted to keep my comments brief since we have had a lot of discussion already, but I did want to bring up an issue that in terms of consistency and the availability of services. We've certainly benefited from Dr. Barr's involvement as a health officer. He's been really critical in our success. The reality, though, is as a small jurisdiction, we have one health officer. And so one of the things we've talked about is what happens if Dr. Barr were to have an unfortunate emergency or chooses to take vacation. He's been very thoughtful to remain available and on call as Dr. Spitters did, but from a consistency standpoint and frankly, for ensuring his ability to take time off, we want to discuss with the board, begin entertaining a discussion about how we have coverage or backup, if we will. And that's something that's critical, and it's actually something that's not built into the public health system in our city. And so the idea is what happens if a health officer is unavailable for consultation? You have to have somebody who approves protocol or who can be consulted on something like tuberculosis or what have you. So this is something that we want to address. The state has been discussing this for many years, and I've been certainly involved in these discussions for at least 7 years now about what we do for coverage. And one of the things that happened over the last year was that the state received funding to create a regional health officer system. So there are health officers now who are regional, who work for the state, and there's one per region. There's 4 regions. And we have a gentleman named Dr. Jay Miller, who is our regional health officer. He does not have authority over the jurisdiction. He does not supersede Dr. Barg at all. He's there for consultation, and often the what we would refer to as the foundational public health issues that we're dealing with, emerging threats, communities, are Dr. Barg's responsibility. There are things that are called added and important services that someone like Dr. Miller might be involved in, but it's not through his authority to oversee what we do. Nonetheless, there is the potential to have a relationship with these regional health officers that could provide backup for Dr. Barg in the event of an emergency. And again, there's 4 of them. So the idea is that they themselves could back each other up. I wanted to introduce this to the board because I think it's important for us to have options for coverage. The other option is that we could partner with another jurisdiction, and then their health officer could back up our health officer and vice versa in the event that we need. So as an example, Benton Franklin Health District is a health district like ours. They're covered by Endurus, our risk pool. We could potentially have a relationship with them, which I have not entertained yet. We have new health officers really around the state, so the old way of doing business is not necessarily how we do it now. But I wanted to introduce that there seem to be two options for backup. One is to have a contracted relationship with another health jurisdiction, or to entertain a contractual relationship with the State Department of Health, where they could back up Dr. Barg in the event that he's unavailable. So it's certainly not time pressing issue, but I did want to discuss it with the board and gain your thoughts and your concerns. I certainly don't want to put effort into something that the board disagrees with, but we do think it's important in terms of continuity of services that we have official health officer oversight.
Andre, can I ask a quick question on clarification? I
Please.
thought if we don't have one of these in place, then the default is actually the state health officer is the one who makes decision for the local jurisdiction. Is that?
Yes, that
Right.
could be. If you were, as an example, not to have a health officer and you did not have an option, long-term, it would default to the state. So the state would be making the decision. So thank you. I think that's great that James brings that up. We're trying to get out in front of that.
Yeah, it's one reason to make sure that you have this in place in terms of what your local health jurisdiction would want to have. So that if your default is not to have a state health officer making your decisions, you'd want to plan this in advance. So that's why we're bringing it to your attention and having the discussion.
And by no means is this for the state to take over. It's just the idea that literally you have to have a physician who makes decisions. Do you want to share how that works here in terms of our protocols, Melissa?
Yeah, we have a lot of standing orders or protocols on things that we routinely do. And Dr. Barg signs off on those as just kind of a blanket, here's our standing orders. So if we didn't have a health officer in a working capacity, we would have to shut down pretty much everything that we do, even up to the cardiovascular vital records. It would affect all of our day-to-day operations.
The health officer is hired by the board or by the executive director.
Well, the board approves the health officer as our health officer, and then we create the contract.
I'm just throwing, I mean, are we overthinking it in the sense, can Dr. Barg purely recommend someone local to serve in his capacity when he's unable to serve? I mean, do we need to have these interlocal agreements on a regional or even a state basis?
Well, there's the complexity that you normally want somebody who's well trained in these areas and has a background in this work. Obviously, infectious disease is something that Dr. Barg knows well. The other is that from a organizational standpoint, you are taking the responsibility and the liability for someone. So we work with our risk pool, essentially our insurance carrier, to ensure that if they make a decision, it's certainly backed up by the organizational liability. So it can't just be someone you know. It could be somebody local, but.
So the other thing to think about, though, is to the extent that that person is there, Dr. Barg would make the recommendation, but then this board would need to have to work through that process and make that decision. So one of the other options in the statute, I think we talked about this before, Ryan, was one of the other options is you can meet as a board to try and figure these out in these emergency situations when they come up. Now, gathering everybody, putting everything together, working through that process, my recommendation is you'd rather be out in front of this rather than dealing with it in real time. So it is an option though, Commissioner, but not one that I would recommend.
I think you also then get into Endurus, our insurance. We don't not covering somebody that Dr. Barg would just happen to choose. And there's.
Well, I would trust Dr. Barg would choose someone with, so I have to be covered.
Yeah, they still covered by our
Yeah,
insurance.
no, that makes sense. So Andre, I mean, you have, out of all the options you've highlighted, what do we feel is the best route, that we're not overworking it, that it's.
Well, in the past, I tried to entertain a relationship with other jurisdictions for coverage. It was very hard to get agreement. There were some health officers that didn't want the responsibility. There are some health officers that were comfortable doing so, but they were on the west side of the mountains, and our board was not interested in having someone from the west side do that. There were some concerns that the board, in fairness, had shared about state control or state oversight. The one interesting thing about the health officer coverage system, and we're having to work with the state because their system has not really been fully vetted, is there's 4 of them. So if one of them is not available or is on vacation, there's a backup for them. So my goal is to have consistency and have availability. Right now, when I've discussed it with the State Department of Health, they've wanted a contract with one individual, and I said, I don't think that's gonna work. If that individual is not available, then you'd have to start a contracting relationship, and when they brought up, well, we would just do that, and I said, well, you're saying you want to do that on a Tuesday at midnight? I mean, it's not an ideal scenario, that it hasn't been addressed. It's not a good system yet, and so I'm trying to protect our interest here at the health district level. I can discuss this with some of our local colleagues about their availability, but in fairness, I want to share with you that my concern in the past was that health officers would grant each other coverage without actually having an official duty or responsibility, which I think from a liability standpoint is a bad idea. So I would like to have an institutional organizational relationship and a memorandum of understanding and approved relationship, because even if a health officer, as an example, says, yes, I'm happy to do so, the board of that jurisdiction may say, we don't want you to do that. So it's very complicated. I'm bringing it to you now, not because, again, we have to make a decision immediately, but I would like to gauge the board's thoughts over the next few months about whether you're comfortable with a state health officer relationship so that you can have regional coverage and multiple backups, or if you'd like me to entertain something at the local level. And I'm happy to do research, but I do think it's necessary because in the event of a major emergency, we have to have coverage. And again, if we're talking about life or death issues, as Melissa said, we cannot by law move forward with care if we don't have someone who can direct that care through protocol. I'm hoping to the physicians in the room that I've said this correctly. Am I catching it, Dr. Bart? Am I saying it correctly? Yes. Thank you. That was succinct.
I think it's important to note too, that if you all chose to do the state health officer approach, this isn't a health officer that's gonna come in and create initiatives. This is somebody who's going to just keep the day-to-day running.
Well, and I guess that's where my gap is on my end. I don't know what the day-to-day workload is. And so I would kind of lean to our providers or the users of who reach out to you on the day-to-day and to see what would be the best solution for them to get that timely response that they need from a health officer, you know, if that's the state system or if it's more of a regional.
Well, I mean,
Efficiency is important to me, I guess.
sure. I mean, we could give an example as a tuberculosis patient who needs immediate care. If that care cannot be given because we are not allowed under protocol to give it, that person doesn't get it.
Yep.
It's just that simple. If you had another Mpox situation, monkeypox, where you are talking about responsibilities and the local health community is looking for you to give direction or clarity on care, we couldn't give it. And if you had a major event, an emergency in the middle of the night and you needed direction, you wouldn't. Commissioner Lindy has his hand up, I believe.
Go ahead, Commissioner. Thank you.
Yeah, thank you. I would just add my opinion that if we need a backup, I would really strongly lead to lean into having a local option versus having to rely on the state as a backup. They know our area and our people and our circumstances.
Thank you. We have any other comments?
Would say that
Go ahead,
more
Doctor.
regional people have been health officers before. So they kind of know the groundwork.
The regional officer in this area, what is the scope of coverage there?
Oh, it's multi-county. And again, though, they are not dealing with direct patient care the way Dr. Borg is consulting with Melissa. So they are more flexible in their issues. So they could be working on, things like PFAS is a concern that people have. So they could be discussing that or something around the idea of communicable diseases in general. Or the issues around the fact that we have preventable illness in this country around heart disease and hypertension, things like that. So their plate is filled differently than ours.
So my question is, there are 4 officers for the state. Each one covers multiple counties. Do we have a choice of those officers?
Well, we've been assigned Dr. Miller, Jay Miller, who's in our area. We've worked with him, we've met with him, he's very cordial. But he doesn't have any authority essentially in terms of what we do here. So we could entertain a relationship to allow him to be a backup. And we could be very clear in our contractual relationship what that entails.
Our area is, where Dr. Miller is kind of to the south of us and then to the west of us, those counties.
Okay, so
Lewis County.
primarily on the eastern part of the state is my,
No,
no?
no,
No.
that's Klickitat, and then it goes to the west, like Lewis County and for the west.
I asked that question because what you shared before, Mr. Fusco, was that the board previously was not interested in having someone from the west side fill that capacity.
Yes, and we didn't have agreement or consultation about these regions. You know, it is an odd system. I'm choosing to look at it in terms of coverage. My expectation is that we have someone who's well-trained, who knows the work and who can ensure the longevity of our healthcare that we provide to the community. But it is an issue that has been raised by the board in terms of having someone local. So that's why we wanted to bring it to your attention. What I can do is begin the research on other options locally for coverage and bring it to you in our December meeting. If you'd like.
I would appreciate that. The only other obvious solution is that Dr. Barr could get no time off.
Right.
You can never leave.
When standing orders are perfect, you know, a lot of times we don't have to call Dr. Barr, but when we're taking care of an active TB patient who might be having symptoms or we're concerned about their labs, we have to get that order approval through Dr. Barr. So that's where we need somebody readily available to be able to call.
Well, and we should always have a contingency plan,
Yes.
and it doesn't sound like we have one outlined, so this is a good opportunity for that.
Yes, agreed. Any other comments or questions by the board at this point? Then we'll look forward to Mr. Fusco to what you bring to us.
Thank you so much.
Right. Then we'll move on to the Chief Operating Officer, Mr. Iba.
Okay, I'll start out with our emergency preparedness update. The Yakima Health District is working with the Yakima County Human Services to develop and improve the resources for cold weather shelters for the citizens of Yakima County. We're also, today, we have a virtual audit from the State Department of Health for our regarding our emergency response and coordination. That's a pretty simple audit where just a couple hours long. It's virtual and just answering questions about our deliverables, what we did this last fiscal year, what our deliverables are in the upcoming year, and how we're going to achieve those deliverables. And then finally, we have in storage, we had about 50 pallets of PPE that were given to us from the state for COVID response, and about which equals about $500,000. And so the county needs that storage space back. And so we have been working with partners from anywhere from public agencies, medical facilities, charitable organizations, and private industry to distribute all this PPE. And this PPE consisted of N95 masks, nitrile gloves, hospital beds, and accessories, ventilators, and those accessories, surgical masks, and isolation gowns. And so we were able to distribute almost all of those 50 pallets and $500,000 worth of PPE to all these organizations. We did have 48 hospital beds that went to hospice, Unique Gospel Mission, Rod's House, Arcadia Medical Facilities, the Yakima Nation, and Lions Club. So as you can see, there's a lot of different agencies, organizations that were involved, but we're happy to announce that we're able to distribute throughout all that stuff throughout the county. Any questions on that before I move on?
I've been through that storage and I was like, wow, it's a lot.
Yes.
It's a lot. And a tremendous amount of investment.
And who would have thought that PPE expires? You know, there's an expiration.
Well, it's hard to give away 48 beds too. You'd think everybody would want it. It was a lot of work and they're heavy.
And a lot of storage space.
Yeah, and for anyone that doesn't know, PPE is personal protective equipment. The other thing is we have a position that we're going to be advertising in the next couple of weeks. It's a transition specialist in our developmental disabilities program. So if you know anyone that's interested, then send them our way. But yeah, we'll hopefully be advertising in the next couple of weeks, and then maybe the next meeting we'll be able to introduce that person. If not, then in January. And then finally, December is the annual evaluation for our executive director, Andre Fresco. So every year we send out questions to the board for the evaluation. Along with those questions, we will send out the 2023 accomplishments and the 2024 goals for the health district. So those will be going out to you the beginning of November. And so usually we give about 2 weeks to answer those. All the answers are anonymous. So and then we compile a list. Don't necessarily know who says what, but you'll see what everyone's responses are. And that will be part of the executive session in our December meeting, where you can discuss and evaluate our executive director in executive session. All right. That's all I have.
Thank you very much. Any questions? If not, then we move on to our financial report with Mr. Porter.
Thank you. Good morning, everyone. My report starts on page 9 in the board of health packet. But before we get into the financials, I would just like to thank the board for their flexibility on moving the budget hearing to the beginning of the meeting. We don't mention the meeting and Wendy had to drop off, but I was really grateful for them to be able to join us for the vote for that. And it's really nice to have that put to bed. So that we can really look forward to the next year and we'll start planning for what we're going to be doing in 2024. Especially with only just one board meeting left in the year. All right, getting into the financials, for the month of September, we had a gain of approximately 120,000, bringing our exit to $1.8 million for the year. Our allocated revenue through the month of September was 7.4 million, and our actuals coming in to 59 million. While our allocated expenditures was about 7.6 million, and our actual expenditures coming in at 7 million. Any questions on the summary? I'm going to move quickly. Time, but if there's any questions, please stop me. Moving into the income statement, same with the trends that we've had this year. FPHS has been a major funding source, and we have an overage and developmental disability to pass through entities. The real winner through 9 months of the year is our investment income. That's just it's very, very surprising to see that tick up the way that's ticked up. $700,000 in a year. Really, the expenses, moving down into the expense section. A lot of the same trends that we've been seeing throughout the year. We have an overage in our provider services for DD, which was expected, and contracted services, which was for maintaining and updating Acela, which is our permitting system. Any questions on this part of the income statement? Moving into the second page. Again, the overview in this part has to do with our laboratory and pharmacy, our naloxone purchases, and then also our small tools and equipment, which is a lot of our building update. A lot of the equipment and the sneaking that we have here. Okay. Moving down into the program specific, I have no real comments at this point in time. And the clay section being the FPHS, and that'll actually start to grow a little bit as we add some additional FPHS programs in the next year. Next page. Again, not much to highlight on this section unless there's questions. Okay, and then the COVID income statement. We are seeing an uptick in advertising, and we will see some more advertising coming through in the next couple of months. A lot of it is moving into the cold weather season. We're starting to see an uptick in certain diseases, so we're trying to get the word out. All right, last page is our cash flow. As expected, we had a slight decrease in cash for September. We have our major funding comes in January and July. This past year, it came in July 31st, but it got posted August 1st. And that was a little bit of a timing difference. That's why you see the timing go up to August. Any questions?
I swear you've answered this question probably 20 times now, but the COVID money for the federal stuff, that's not something that we're going to have to return at the end of the year. Yes. Because there's about 500,000 we haven't utilized.
Correct. It is a reimbursement only.
No, it's reimbursement.
Right.
So it's available to us. We invoice against it.
Will we have that for 2024? No, okay.
It's through
mid 2024. We have guaranteed through the end of June 2024. But that's our only guaranteed so far.
Right on. Thank you.
Thank you, Cory. If there's no other questions, we will move on to our health officer, Dr. Lamar.
Good morning. So I have a couple of things to talk about. There was a study done by University of Washington, which we touched on last month. What they did is they looked at random surfaces in public transportation, both in Seattle and in Oregon and Portland. And they did not detect enough to present any danger. So we need to you know, these are places where you might not expect to find anything, but they don't have any visible fentanyl laced drugs. So there's still a possibility, like the one example we gave, the little kid finding a little envelope with pure drug in it. Also, there's some rescue EMT people who might go to pick up a person who overdosed and they're covered with fentanyl laced drug. So those are not part, but those are areas where there might be suspicion that it's present in high enough concentrations to cause problems. So the risk of taking public transportation in Portland and Seattle and being exposed to fentanyl at its quantity sufficient to cause problems is extremely low. And they had some recommendations about further measures to take, like increasing ventilation, better deep cleaning, and educating the public transit workers about what happens if there is an exposure. So not too much to worry about if you want to the right rail next season, since they're out of it this season. A little clarification on the RSV vaccine. So it's recommended for adults over 60, and in particular, those adults who have underlying medical problems. So as a healthy 65-year-old, it's not something you have to worry about too much. If you want to get it, fine, but you're not putting yourself at undue risk. The other thing is for kids, right, the recommendations are the RSV causes a problem in very young kids. The recommendation is for pregnant women who are between 32 and 36 weeks of pregnancy in the season of RSV, September to January, that they receive the RSV vaccine. They will develop antibodies which will cross the placenta into the kid, and the kid will be protected during that first 6 months of life, which is where the highest risk is. So it's a little bit different than just kids getting it. That's not the issue. It's moms getting it to protect the kids during the high risk time of the year and the high risk time of those kids' life. A little bit about the Shigella outbreak. It's still ongoing, but we have enough data to know confidently that it's not a multi-drug resistant, antibiotic resistant organism. It's resistant to a commonly used antibiotic called Bactrim, but a safer drug to use and less of a problem with side effects. Amoxicillin, which probably lots of you have heard of before, that's capable of killing the organism. And everybody that gets it, the recommendation is not to treat it, just those people with underlying medical problems. It's otherwise a self-limited illness. There are other species of Shigella that cause much more severe disease. This is not one of them. And that's pretty much it for today's report.
Thank you, Dr. Varg. Any questions? All right, then we will move on to disease control non-specific.
Let's continue with off of what Dr. Bark said. We still are currently having our Shigella outbreak. We're currently at 82 cases year to date compared to 11 at this time last year. We've done a lot of community outreach to providers, daycare centers, and the community in general on Shigella. We are working on our child death review. We should have our first meeting in January based around suicide. We've also confirmed with our final person for our kind of our core group. So that'll involve EMS, the sheriff's department, physicians, nurses. So we're getting that up and running again. COVID, we're seeing a decrease in our activity. We were up last month. We had 12 outbreaks at our last Board of Health meeting. We're down to 4 outbreaks. So that's great news. We're seeing some low or minimal RSV and flu in the county right now. We usually peak though in December, January. So we'll keep monitoring that. That's it for me, unless there's questions.
Thank you. Any questions for Melissa? Hearing none, then we move on to environmental health and where did John go? Well, apparently there's no report. Okay, we're going to skip that and come back. We will move to public health partnerships with Lillian Bravo.
Thank you. And then just to go off of what Melissa was saying, given the peak into flu season and COVID is still coming, we do have a website, yakimavaccines.org and yakimavacunas.org, with a list of locations where people can still get their vaccination for COVID and RSV. There's also information about when we host community events. through the DOH Caravan. And that's where people that are underinsured or uninsured can get the vaccine for free. So we'll actually be working with pharmacies because that is a growing issue in our community. People are wanting to get the vaccine, but perhaps don't have insurance. And so these locations, the DOH Caravan locations, are where people can go to get that. And again, that's on our website, and we update it weekly to take into account any shortages on vaccine as we've been hearing about, locally at least. And moving on, I did want to give an update on some of the work that we'll be doing moving forward with around youth substance use prevention specifically. So we will be moving forward with working with ESD 105. ESD 105 currently hosts most of the contracts here in Yakima County for what's called Community Wellness Prevention Initiatives. They're also known as CWPIs for short. CWPIs are community coalitions that are funded through the Healthcare Authority in high-risk areas, specifically around youth substance use prevention. And in Yakima, the high-need areas are identified. The locations that have been funded are Yakima, the city of Yakima, Wapato, Sunnyside, Pettit, and White Swan. Of course, we know that there's much more need in our community, but those are the sites that are currently selected through that grant program. So what we'll be doing with those coalitions is working with them to enhance the work that they're already doing. They've let us know that they would like our support to grow some of the various different initiatives, but some of the highlights would be doing more events across more communities, specifically around healthy youth, healthy families. These events are in-person events that bring together families to show lots of information about the current trends within youth substance use, but also actually providing a mock setup of a teen's bedroom, and so that they can help the families understand what does youth substance use look like. It's always changing, and be able to identify what some red flags may be so the families can intervene with their children in a timely manner. Also even teaching things such as like how our kids talking about it, what emojis mean certain things. And it's again, just making sure that the families are involved with the information that they need to, again, address these issues in their children as soon as they see it, and helping how to take a family-based approach. So that's one of the pieces that we'll be helping with this, again, making sure that this event isn't just once a year in these 5 communities, but making sure that it can reach all of our different school districts multiple times a year with additional resources, such as providing Narcan, providing additional training, and making sure that it's a valuable event that can reach, again, all of our community members. In addition to that, there is quite a bit of work, again, focusing on families called Strengthening Families, which is an evidence-based curriculum that's being implemented across a couple different middle schools. So again, being able to provide additional resources so that can be made available to more school districts and more families. So a lot of, again, great work that's already taking place that we'll be supporting to enhance the existing efforts. So I'm looking forward. There's several other things, like again, the different youth-based campaigns that we'll be partnering with to make sure that this messaging is created by our local youth and can be disseminated by the youth as well, but in partnership with these existing coalitions. And it's great because it's part of their existing work plan that they need to do as a coalition. So it's a great partnership to advance the goals of both of the organizations. And again, just acknowledge the great work that's already happening and being able to help them achieve their goals as well. So I'll be happy to report on the highlights as we have them in the next couple of months. But I did want to share a quick update on just what some of the things that are going to be coming are.
Thank you. I do want to say, I appreciate that the educational efforts focus on both the parents and the family as well as the youth themselves, 2 different approaches toward the same issues and concerns. So thank you for that. Any other questions or comments?
Are the vending machines placed?
Yes, so that's my next update. So yes, both vending machines have been placed. So one location in Yakima and one location in Toppenish. So the location in Toppenish, we were able to work in partnership with the Yakima Nation Tribunal Council actually to have that approved to be at the Yakima in Toppenish, which is a gas station. It's available, it's open 24 hours and so that particular location is available to community members for 24 hours a day. The location here in Yakima was in partnership with the Opportunities Industrialization Center, also known as OIC, specifically their location on 5th Avenue and off of Fruitvale Boulevard. That location is only available Monday through Friday, 7 a.m. to 6 p.m. But both both machines have been placed and are operational. We are taking the next week to make sure that we get all the kinks sorted out, but starting on November 1st, we'll be announcing that widely and making sure that we send out the press release and all community members are aware that they can move forward, but it has actually been used already. So no major issues that have been coming up, but we're happy to announce that they've both been placed.
Lillian, do you feel that like, because we have a meeting in December, right? We might be able to look at some of the data.
Oh, absolutely.
Okay.
Yep. And that's a good, the pieces that we're figuring, we're making sure that are in working order over the next week to make sure that the data is actually matching up. We're taking stock and all of those pieces, but yeah, we'll have plenty of data. I'm already looking at it.
Lillian, we didn't have an opportunity to put it in a place that would have 24-hour access.
Not in Yakima, not for various reasons, no, not at this time. That is still the goal. And so, but at this point in time, we did talk to quite a few different business owners, different government agencies, different organizations. It just didn't work out for various reasons. But either way, we are very confident in this particular location, and we can look at additional opportunities in the future.
But the Yakima is 24
The
hours.
Yakima is 24 hours, yes. And I mean, that's gonna be one of the pieces that we can see again, just how, when people are utilizing it as well, so we can definitely take a deeper dive to further the search in the future as well.
So there was a great deal of interest, but not every organization. And I did want to give a compliment to the staff. The number of people working on this, it's many here, lots of calls, lots of partnership. But also the board had supported our interest not only in the distribution of naloxone. I don't know if you want to touch on the education piece and the connection to the potential for recovery resources.
Yes, so with each Narcan vending machine, there is education that's been placed on each and every kit, as well as on the machine itself. And a portion of that does include direct information on all the treatment organizations that are available in our community. We also were able to work with Triumph Treatment Center specifically to actually place posters on the machine itself with pictures of the individuals who are the actual treatment recovery coaches, just to add that personal touch as well for people who are wanting to move towards recovery in both English and in Spanish as well. So we are very intentional about making sure that we provide as much information as possible, and making sure that if people are interested or know someone that is wanting those resources, that it's easily accessible from each and every stop at the machine itself.
Thank you.
Thank you.
Any other questions or is there anything else?
I have a question. I'd like to go back to the youth prevention stuff. This really delights me. This is exciting. Okay, so you mentioned enhancing work already being done with the community wellness prevention initiative. So is that just with ESD 105 overall, or is it with each community individually?
So the way that we've been working, it's with ESD 105 primarily as a lead contact, but it'll be with the intention of working within each community specifically, and not just the 5 that were mentioned, but also making sure that other school districts that don't have a CWPI in place can also benefit from these events as well that have already been vetted through these existing groups.
Yeah, thank you.
Anything else? All right, then we will move back to our environmental health report from Sean McGee.
All right, so at the last meeting, there was some talk around water quality testing and then testing of also wastewater for different disease and disease prevalence in communities. So I kind of looked into that a little bit more to give you all an update based on some of those questions. So here in Washington, our State Department of Health does have an epidemiology team that evaluates wastewater that's been tested for disease. The big ones in Washington really are polio and COVID right now. So they use that to identify where polio may exist, or COVID, really the trends, if it's trending upward, trending downward, prevalence of disease within a community. There are private entities out there or companies out there that can test wastewater for a whole host of different disease: RSV, COVID, norovirus, rotavirus, monkeypox, Hep A. Anything that really is shed via the fecal route can be tested through community's wastewater treatment plant. But the big ones for Washington State currently are COVID and polio. Our wastewater treatment plant here in Yakima, that serves the city of Yakima. I know there is the DOH EPI team does collect samples and test for COVID at that location currently. So we don't really see I don't really get the results of that, but they are available on the website. But I can request results from those tests if that would interest the board. So it's really a mechanism to monitor prevalence of disease in a certain area is what it's used for. But it has to be a disease that is shed via the fecal route. So something like PFAS may not be something that's shed that route because it is bioaccumulative. It builds over time. The body doesn't really get rid of it. That's what I've found.
Any questions or discussion?
Well, I think I must have missed where the dialogue was at the past board meeting, but were we entertaining the thought of potentially starting to monitor all of our sewage in the county to see trends? Is that kind of what we were?
I think it was a question, some of the criteria, we're talking about drinking water and testing for PFAS and other things, like especially through our Group B systems. I think the question came up is how do we, is there any analysis on wastewater to test for disease in the area? And there is, it's present. It's just not as, I think, beyond the state level, they're looking at, some areas of concern, certain diseases versus like the private sector, they'll test for whatever you want them to test for.
So like with COVID, because the patient-specific tests are not being done very much. There's no surveillance that you can do and say, oh, we've had 25 cases last week, and they see because they're being tested at home and they decide not to go to work. And so that information doesn't get into any public health reporting. So you can get an indirect measurement of the burden of the COVID virus from wastewater. And that's when they say the titers are going down. So the amount of COVID virus in the wastewater sample is decreasing, which means there's less COVID in the community. So it's an indirect measurement of what's going on. And that's true for polio as well. The monitoring in New York, where they discovered the cases, they were able to get enough polio virus genetic material that they could see mutation in that was avoids the vaccine. It's a tool.
Yeah. In other news, so tomorrow evening we're having an event down in at the Sunnyside Community Center surrounding the Lower Yakima Valley Groundwater Management Area, WAMA. Our staff will be present and basically discussing some of the research data that we gathered through our pilot project for the bottled water delivery and some of the community focus groups that were held and surveys that we sent out and received covering that data and bringing some more educational material in that community. We've also invited our partners, Yakima County, Department of Ecology and State Department of Health to come down and discuss some of the things they're working on and some of the future actions within the WAMA as well. So that's tomorrow at the Sunnyside Community Center from 4 p.m. to 7 p.m. So that we're excited to be hosting that event. There's a lot happening within the WAMA right now as far as different initiatives moving forward with well sampling and community outreach. Also, Lillian updated me that our website now has a section on the management water system to provide updates and resources for folks there. We are in the realm of solid waste, the DTG limited purpose landfill. I believe the public comment period for the clean air permit ends today. So there should be a hearing on that. I don't have the time on that hearing. It's going to be virtual. Last update I got, there was no real public comments that challenged the air emissions of the landfill. So it sounds like there will continue forward towards a clean air permit. But then again, that I'll get in touch with Mark at Wire, our CAA, to get confirmation on that. The clean air permit's the last component that DTG needs to complete before they'd be eligible to have a solid waste permit reissued by the Yakima Health District. So we're getting closer there and making progress. That's all my updates I have for today.
Thank you. Any questions? That brings us to new business. We have none listed. Does anyone on the board have new business? Hearing none, I would then entertain the motion to adjourn to our next regular scheduled board meeting on December the 6th, 2020.
Comment was either made comment that fell in the back.
No, you didn't want
Yeah.
to.
But thank you for waiting for a motion.
Motion.
I'll second.
So we have a motion and second to adjourn to the next scheduled meeting. All in favor, please say aye.
Aye.
Any opposed? You are adjourned then. Thank you very much.